Good morning, ladies and gentlemen, and thank you for waiting. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Janelle Shearer. Ms. Shearer, the floor is yours.
Hi, everybody, and welcome to the Rural Palliative Care Networking Group today. This group, just to give you a little background, it meets 3 times a year, and the purpose is for people to network and learn from each other about providing palliative care in rural setting. And we welcome folks from all disciplines and settings to participate in this. Participation is free. And part of the educational session today will be on POLST. The name of the presentation is Implementing a POLST-type Advanced Care Planning Model, One Rural Community's Journey. And I'd like to introduce our speakers today, and then we'll turn the presentation over to them. So we have Nancy Hall, who is a DNP RN from Bemidji State University. She's a teacher, and she also has a long-standing partnership with Sanford Health in Bemidji. Speaking with her is Mark Tapke-Larson, who is a chaplain. He is the Advanced Care Planning Coordinator at Sanford Health in Bemidji. So we'll turn it over to you now, Nancy and Mark, and thank you so much for presenting about your community's experience.
Move the slide forward here, and
okay. And thanks to you guys for participating today. We, Mark and I have worked together for a long time on advanced care planning, and we just wanted to tell you, first of all, to start out that we're not here talking about this because we have all the answers for you or because we have this totally managed, but we have a good start here in Bemidji on implementing a POLST-type advanced care planning model, and we have not given up, and so here we are to talk with you about that. I'll just thank you for your patience as I get this slide thing here, advancing. There we go. What we're hoping to accomplish with you guys today is to be able to describe to you some of the advantages of a facilitated conversation in generating a POLST document. We're aware that POLST is used in a variety of ways around our state and around the country, and we are great proponents for the use of a POLST document along with a facilitated conversation. And we'll be talking about that. We'd also like to just identify some barriers and facilitators to the implementation of POLST-type advanced care planning, issues that we've run into as we have attempted to implement this process here in Bemidji. So the first thing we kind of like to do is determine who is here today. What professions or roles are represented, and these are the choices that we have available to you, and we're going to do some polling with this question to see exactly who is here. I believe that will happen on the next slide. Oh. Okay, so this will be an opportunity for you to go ahead and respond.
I believe you have about 30 seconds.
Emily, could you please pull up the polling?
Thank you.
Thank you. Well, we're waiting here. I don't see any response from our end yet. Oh, it's just at 9. Oh, gotta wait a little longer. Okay.
Looks like the polling is closed. We don't, oh, there we go. So it looks like 9 of the 15 of you that are on right now are nurses. And we have 3 social workers and a chaplain, an administrator, an other person, which we don't know what it is, and also someone who wasn't able to respond at that time. So a nice mix of people who are working with advanced care planning. Thank you. Another question we'd like to know is the next polling question would be whether or not you have any experience with the POLST paradigm, if you're currently working with POLST documents, whether you're an experienced POLST facilitator in facilitating POLST-type advanced care planning conversations, and whether you've ever been present during or participated in a medical procedure and wondered to yourself, would this person really want to have this done? So we'll ask you to take a few seconds to respond to those questions.
Because there are more questions, you have about 45 seconds to respond.
Okay, and it looks like 13 out of 18 now do have some experience with POLST.
Great.
Yeah. 12 out of 18 are currently using a POLST document. 5 out of 18 are POLST facilitators, experienced POLST facilitators, and 12 out of 18 have been in the situation where we've been participating in a procedure and really wondered whether or not that person wanted to have this done, which is kind of at the heart of why we care about this and why we do this in the first place, is to be sure that we aren't experiencing that with increasing frequency. Thanks for your responses. We'd like to talk first of all, just starting out, about the big picture of advanced care planning, and again, why we care about this. More people in America certainly are dying of progressive illness. I don't think that's news much to any of us. A recent study by Meyer in 2010 indicated that more than 70% of deaths are likely to occur in hospitals and nursing homes, so under the care of others. More than 70.3% of adults over 60 who needed treatment decisions made at the end of life were unable to make those decisions, and that was a different study also done in 2010. So a large percent of people who will need decisions at end of life will not be able to make those decisions. We know that when uncertainty about end-of-life decisions exists, healthcare professionals are very likely to default to more aggressive treatment approaches. And we know also from this study done with a group of cancer patients by Wright et al. In 2008, that more aggressive care at the end of life does result in poor quality of life for the patient, and it also results in a higher incidence of regret, as well as poor quality of life, as well as major depressive disorder for the bereaved caregivers following death. We know that decisions made in advance of the end of life and communicated effectively to healthcare agents and to healthcare providers can really improve the likelihood that end-of-life care will be consistent with the patient's preferences. And that's our big goal standard, that end-of-life care will be consistent with well-informed and well-considered patient preferences. So that's kind of our big goal. We also know from Briggs and Hammett, who have done the Respecting Choices work over at Gunderson in La Crosse, if healthcare professionals or loved ones have not spoken with the patient about end-of-life issues, really they cannot reliably predict what the patient would have chosen, and that makes the decision-making responsibility more burdensome and more stressful. I think that's probably not a surprise to any of us. So the goals of advanced care planning and what we're trying to accomplish in the big picture, is that in the event of decisional incapacity, you'd be able to maximize the likelihood that medical care serves the patient's goals, minimize the likelihood of over-treatment or under-treatment in relation, again, to the patient's goals. We'd like to reduce the likelihood of conflicts between family members and close friends and healthcare providers who have a different picture of what should happen for the patient, and then also minimize the burden of decision-making, which can be very painful for family and close friends. So where we've been so far is with the Patient Self-Determination Act passed in the early 90s. We know that advance directives are expected and encouraged, and that we need to ask about those. We also know that there's a relatively low completion rate for advance directives. Around a third of adults complete an advance directive. We know that even if the advance directive is completed, it is often not available when it's needed to support decision making. And often even if it is available, it doesn't influence the care given or the cost of that care. There's multiple studies that have demonstrated that advance directives alone are not achieving the goals that we had hoped for with that Patient Self-Determination Act. Although it was encouraging to find as we updated our data that some recent studies are demonstrating some more optimistic findings. So I'd like to talk a little bit now about patient-centered advanced care planning and what that actually adds to the picture of advanced care planning in general. And what I mean by patient-centered advanced care planning is really a lot about the conversation that goes along with an advanced care planning session. It involves a trained facilitator and a standard discussion guide that addresses beliefs, values, experiences, and understanding of treatment. A patient-centered advanced care planning session includes the patient, the facilitator, and the healthcare agent and other family members if they're interested in participating. It is recommended as a part of good health care just in general, and the plan that's developed is intended to reflect an individual's current health status. The conversation that's part of that patient-centered advanced care planning process is facilitated by a facilitator who's been trained using Respecting Choices concepts through a Respecting Choices training program. And again, includes the patient, healthcare agent, and facilitator. The discussion guide, which you learn how to use in the training program, explores, first of all, patient's experiences. It explores what brings quality to the patient's life. And eventually it explores the patient's understanding of each treatment that they will be making a decision about. The conversation, in a very powerful way, provides context for decision making. So rather than jump into a decision about whether someone would want a life-sustaining treatment, we talk first about what's important to that patient, what they've experienced in their life with other people and with themselves in their own illness that informs their decisions, that sets a context for their goals. We talk about their values, beliefs, experiences, and then move to the knowledge about the treatments they're making decisions about. So that's a really nutshell version of the patient-centered advanced care planning and the conversation that we use. Now I'm going to turn this over to Mark.
Yeah, and actually, if you would go back one slide, Nancy, back to the conversation one. Thank you, Nancy. What I wanted to share right now was a story about, from my perspective as a facilitator. I was a chaplain for 20-plus years before coming to this role as the advanced care planning coordinator. And I did a lot of advanced care planning with people. I had a lot of conversations with people about kinds of treatment decisions that were out there, what they meant, that kind of thing. And so I've kind of been a part of it since the beginning of having those conversations. But what patient-centered advanced care planning adds that I did not have as a resource was that standardized approach of a format that actually works in terms of helping people figure out what it is that they need and giving them a decision kind of matrix for them to make the decision. So I wanted to tell a quick story here about how that conversation works and what it adds to the process. And many of you having these conversations know how this works, especially if you've had the training, because that training really keeps the focus on the patient and the patient's needs and keeps the bias out. So she was a 73-year-old lady who had multiple healthcare problems, dialysis. She was on dialysis, had heart failure, COPD, struggled with alcoholism. And she was referred to our advanced care planning because she had landed up in the hospital again. And so we got that referral, waited till she was discharged and was back into her long-term care setting, and then called to ask about making an appointment to have an advanced care planning conversation. Her daughter answered and said she'd get back, and about 20 minutes later, her sister, patient sister, called me and kind of gave me the quiz. What is this? What do you mean? What are you talking about? And we talked a little bit, and it became clear that her sister was kind of the interpreter of the medical information for the patient. So we set up an advanced care planning conversation. When I explained what it was to her, the sister was very eager to have the conversation. Set it up. So it was right after a doctor's appointment. We started the POLST conversation. And right away, the patient made very little eye contact with me, clearly was not happy to be there having this conversation. So I kind of slowed down, but I followed the format. I followed that process, that conversation, how it's set out. We explored together what an agent's role is. And in that conversation, she did share that after we talked about specifically what an agent's role is, she did decide to make her sister her healthcare agent rather than her daughter, who was, because her sister was, as she said, always there for me. And then we explored her illness process. The sister very much involved, the patient nodding and doing some teach back to make sure she understood. Talked about complications, explored some of the experiences she had making those up with other family members making those decisions, including a daughter of hers who had died in a car accident. And then we talked about what it meant for her to live well. All of this was maybe 30 minutes into the conversation. And in that, the very last question in that living well process is, what helps you face challenges, difficulties you've had? And one of the first times she looked at me directly in my face, eye to eye, and said, "I don't think about it." So, boom, the conversation allowed that to come out, and that was wonderful because up to this point, every hospitalization she'd been asked directly, "Do you want us to start your heart again to stop?" And she's always deferred making decisions because she doesn't like to think about it, so she's always been full cold. Well, through the process of our conversation that followed after that, talking through using a decision-making matrix with the talking about CPR, she decided she didn't want to have CPR done, which surprised her sister. A little more conversation, and it turned out that she didn't want it done because she had been told in Fargo when she had her last heart procedure, and they told her they wouldn't do any more for her, that CPR would not, that she said, the doctor told me CPR wouldn't work. That's how she made her decision, and she brought her decision-making process became clear through using this tool, and so she was able to say, "No, I don't want CPR," by pointing to the doctor. That allowed us then to, when we came to the ventilator and other discussions, to set it up with the doctor, to key in the physician that the physician needed to be a part of it and how they needed to be a part of it. That story, for me, is really illustrative of how the process of patient-centered advanced care planning, not just doing the POLST document, but having the conversation in a formatted way, really helps patients express their values and goals. So, what is the POLST action big picture? Well, here, unfortunately, we can't show you this video, but for your reference, please go. If you got a minute, 5 minutes actually, take a look at it. It just is from Lee's perspective. So I told you mine from my facilitator's perspective. This is the story from the patient's perspective about how important POLST was for her in terms of being able to allow her to really guide the last days of her life, being really able to feel like she had a voice kidney failure, neurological disorders, and really those who are living in long-term care facilities. The goal is to really communicate what it is that patients' preferences are with their full understanding of what it means to make those decisions. So it's really a lot about filling in their knowledge gap and then providing them the resources to understand their choices. And I found over and over when I do this, people can make those decisions when their understanding is taken into account and when they get the knowledge that they need. And the document can move across our healthcare continuum. It's the only document in Bemidji I know of that will be honored by the EMTs, by our long-term care facilities at the hospital, all of those places. Next slide. So the Respecting Choices model, the one I've been training, the one we're using here at Bemidji, it approaches it from that patient-centered perspective, provides a facilitated conversation, and it's facilitated by a trained healthcare professional. And the POLST-type advanced care planning follows that standard guide form. If you've been trained in that form, when I talked about exploring the illness, exploring the complications, exploring experiences, exploring what living well meant, those would be very familiar terms to that. We do that with all of our patients. Oh, and then it also produces a narrative at the end, which builds then trust with the physician. They get the document, talks about CPR, whether they want or not, and they've got documentation about that. And the evidence for both, I think the first one is really an interesting one. Healthcare professionals find it useful. They found it useful because those end-of-life conversations happen in a way that produces treatment decisions for people based in their context. The discrepancy or decreases frequency of unwanted resuscitation attempts. People actually get a chance to say, no, I don't want that, knowing what it is. Increases the number of people who have more than resuscitation orders on their chart. And increases the care at end of life that is consistent with what the patients say that they want. And then Nancy provides this information. She is a consummate teacher, and there's a lot more of this information at the end for you.
When you guys want to write a paper about this.
That's right. Good place to start.
I promise I'll get past this.
Okay.
The document.
Oh, yes.
Yeah.
Okay. So what we wanted to do is you folks are working with the POLST, so I'm going to go through this real quickly. Process. It's just we wanted to show you the POLST document and then just break it down for you a little bit, what the parts are. Of course, the documentation preference addresses those basic ones, resuscitation, and that the goals of care is really important because it sets the direction and the tone for what will come. I find that very helpful with patients and their agents to have that particular conversation because it really sets the tone, moves away from specific treatments to more how are we going to approach this. Okay. Oh, and when it's signed by a provider, it functions across settings, which is really a wonderful thing. The reason I chunked it up here a little bit is the first one, doesn't it look like that's a simple thing? I know there are places that are using the POLST document out there much like a DNR form because it has this little box here where you can check one box or another. But what I want to show you this because when this is effective, it's the conversation that comes before it, where you talk with a patient about what they truly understand what CPR is, filled in the knowledge gaps, when you really help them understand how their goals and values might fit with making the decision to have it or not have it, and then deal with their fears and concerns. So it's a little bit here, but it's a large conversation behind it. This is the goals of treatment section, again, where you talk about the three different goals of treatment and how they might be used. The first one really is to help people in those final days of their illness process when they really do not want other treatment. The second one is to really help them maintain the quality of the life where it's at that time. And the last one is provide all that care that a person needs. And this last section on the front talks about the use of antibiotics and nutrition and hydration. That first section of antibiotics, I find most of the time people do want to use IVIM, antibiotic treatment. There's really not a clear understanding for most people about whether that would be helpful or not at the end of life, because for most people that's kind of we do that because it's taken care of. It's a good thing. So that one often takes some conversation and reflection with it. And then the hydration section, feed, tube feeding. All of that provides opportunities to have those conversations about what would that mean if you're coming to the end of life, as opposed to what does that mean if I've been in a car accident and I need something. And then the physician signs it at the bottom. On the back, I think a really strong part of this document is that it really identifies who is there, including the facilitator's name and responses. I think that adds credibility to the document. If I call you for a doctor, the doctor can call me up and say, what is this about? How did this come about? What's important? And then the signature, which is not required. The doctor's signature is what's required because it is a actionable medical order. So we don't have patients sign other orders. This one, we have it in there, and I don't think there's ever a time when I haven't had them sign it to make sure that they, again, assent to what's on there. And then our documentation template. This is the documentation that we use, the way we organize it, and it follows the flow of the conversation that we've had to really let physicians know, oh, this conversation has had some depth to it. Quite often, when we use this, we use quotes from individuals. I try to make sure every time there are quotes from the individual in there about, all that's really left for me to enjoy is my grandkids. If I can't see them, I don't really want to live any longer. A quote like those kinds of things. So now we'd like to do a little demo for you. And I'll set it up for you here. And what Nancy and I will do is just kind of talk through one of the little sections of this using the advanced care planning, that model and framework. So just to set it up, Nancy will be Samantha Short, 80 years old. She's had 6 years. She's been a resident in a local long-term care facility. She's really, the last 6 months have not been good for her. Because of that changes in the last hospitalization, the primary care provider decided that he would not be surprised if she were to die in the next 12 months. That's really the criteria for the POLST conversation. And then, called up, set up an appointment. Samantha has been in the hospital a lot, COPD, heart failure, diabetes. And so we've been having these conversations. We'll pick it up after 45 minutes of the conversation. So we've talked about who an agent is. Her daughter, of course, was picked out before we started, and she was the one that she wanted to make a decision. We've explored her understanding of her condition, her understanding of potential complications, her experiences taking care of her husband and several others who are coming to the end of life, and what living well meant to her and what it means to her right now, even because things have changed for her over the last year or so. And in that context, Ms. Short decided she didn't want to have CPR because she didn't, when she heard about what it was, when she heard about how effective it is and how ineffective, how it's not effective for most people in long-term care settings, she decided she didn't want that. So we'll pick it up. And we've got this. This is the section that we'll be talking about. So you can just have it in front of you. And I'll use that technique that we use, unfortunately. Well, Mrs. Short, thank you so much for the conversation that we've had right now. And I can see when you thought about making that decision about CPR, that that wasn't really very hard for you to make that decision. It seemed like, can you tell me what you were thinking when you made that decision?
Well, I've had a good life and been lucky that way. And when you talk about, well, that it's probably not going to bring me back. And even if it brought me back, it wouldn't take away my heart disease, or it wouldn't leave me any better off, and it might leave me worse off. So it seems like logical to forego that kind of drama, and I really don't want to go back to the hospital.
Yeah, you bet. Well, now that we've made that decision, there is another set of decisions that we want to talk about that is important for your healthcare providers to know how you might like to approach the kind of goals for your treatment as your health has been changing. And so I want to give you the options that there are, lay them out for you. And the way I'd like to show you is, here's the document, and the way I'd like to show you is, I'd like to start with the one that reflects most what I've heard you been saying over our conversation about your grandkids and their importance, about how you've had to limit things in your life quite a bit, but also how you're continuing to enjoy them when they come over, as long as they, like you said, as long as they don't stay too long. Okay. So the option I'd like to start with is this middle one called Limited Interventions and Treat Reversible Conditions. Really what that means is that what we're asking your healthcare providers to do is help you, if you get something that they can take care of and help you through an infection of some kind, and they can cure that, help you through it, so that it'll return to where you're at right now, then we would pursue those kinds of treatments. Those are the ones we do. So they wouldn't do aggressive treatments, because that doesn't really fit with what you were saying you wanted, but they would do rather treatments that would help you maintain your situation where you are. So you might quite likely go to the ER to get some of those treatments done, because you've been back and forth before. But the goal would be just to take care of those treatments, those things that would be new or we can communicate. Does that make sense?
So it does. I don't want to just totally give up and not do anything.
Right.
But the last time on that respirator in that intensive care unit, that was really hard on me. And so it would be okay to go to the hospital, but I don't want to go back to that intensive care unit and have that breathing machine. That was really hard on me. And I couldn't talk to anyone. It was tough.
Okay. Well, that's one of the decisions that we need to make here is how would you like to use intubation? And it sounds like you don't want to have that tube put down your throat anymore.
It was pretty tough, yeah. Yeah, if they can find a way that I could be a little more comfortable, but not have that machine.
Not have that machine.
Yeah, it would. I understand that might mean I would die, but I don't want to have that machine again.
Okay. Well, then what we can do is we can put down on here that you want to treat limited conditions, you want limited interventions and treat reversible conditions, but you do not want to be intubated.
Yep.
Okay. Thank you. And so coming out of our little demo there, I'll go to the next page. What I did was I introduced the goals of care. We started with CPR just to make that transition in. Introduced the goals of care. We started with the patient's preference, where the patient's preference was. We discussed. We should have discussed all three of those options. I didn't do that as I should have. And then I did a little teach back in terms of what did you think, what did you hear for that. So that's kind of how that conversation goes. And it's really effective in helping people get to those. So now I'm going to go through Bemidji's story really quickly here for you.
Mark, this is Janelle. Could you just speak up a little bit?
Sure. I want to go through Bemidji, what we've done in Bemidji a little bit for you. This slide, there's a lot on it, but the core of the slide is what we did is we got some energy behind programs that keep moving forward, the patient-centered approach, because it takes time and it takes resources. So there are 3 grants that are buried in this information. The first one was a local one. First one was one from Status Health to help organize this. Second one was a local one to get it energized and moving forward. And the third one was a large one from the state of Minnesota that really enabled us to move it into the healthcare system. So that shows that progresses. And it's taken us this long to really get it really embedded. So what our goals for this next year is, we're now moving advanced care planning, both the first steps and the POLST-type, into our internal medicine clinics. We're doing an initiative right now, working with nurses to try to get them to do more referrals to us. We're going to be moving that into the family practice setting. And we're working with our dialysis to get POLST into those settings. It's a struggle. We've done work with the dialysis before, and it hasn't really worked out for them to actually do POLST conversations, so we're going back at it again with what we learned the first time when it didn't work. And we're going to be offering, we have POLST sites throughout the city, long-term care settings, assisted living settings, and we'll keep supporting those folks. We're going to also goal to increase the number of advanced care plans, particularly with our COPD population, which is an emphasis that Stanford Health is now moving forward, and it really fits with us, and so really dovetailing with that and using that energy from that. Major activities for implementation, the top one, the first one is leadership engagement to using patient-centered advanced care planning. It's resource intensive. Leadership needs to know the value of it and why they would want to spend money to do this. And that's been an ongoing challenge for us to get that out. To identify the key stakeholders throughout the community was really important for us. At the beginning, it was a very community-wide movement to really figure out who is going to help move it forward in their particular agencies, those pilot agencies, and what they need to do. To have the conversations with each setting about what they need in their setting. How do the workflows work for you in those venue meetings? To train the facilitators and give them ongoing support. To do quality improvement activities, to try to look at not just the number of POLST that you got, but are they consistent when you look at them? Do they actually make sense? Is there any documentation with them? Those kinds of things. And then financing the operation, that's the ongoing challenge for sure.
We wanted to talk a little bit about what have been for us the challenges to implementation. You could see from our table earlier that we've been at this for a while. And one of the larger challenges is that this kind of advanced care planning is really a culture change. We have worked with many, many professionals who love the idea of POLST, and particularly of POLST-type advanced care planning in their Respecting Choices model. You know, we do facilitator training and get some strong people really on board and very excited about it. And then when they go back into their settings, the challenge for them to actually make the process happen effectively with the same resources that were available to them before they came to us is a big challenge and has been one. That results certainly in competing priorities for resources. And our facilitators especially have borne the burden of this because they would very much like to implement POLST-type advanced care planning, but finding the time to get this meeting scheduled and to actually have time with the patients to do that's been a challenge for them. One of the things we learned from this is to be really careful about who we choose to be facilitators, based not only on their skill and interest, but also on their ability to potentially implement it in the role that they're currently in. And we have developed an agreement of understanding that we have our agencies that we're implementing in, and also the facilitators take a look at and kind of sign off on an agreement, so it's really clear to them up front that there is a commitment of resources that will be required to implement. Productivity requirements are clearly a challenge. Reimbursement is a challenge, although apparently we're making a tiny bit of progress in reimbursement. In the past, advanced care planning has not been a reimbursable service, and now just very recently, CMS has determined a reimbursement mechanism for providers to do advanced care planning, and with some assistance under particular circumstances. So although due to the complexity of that rule, it's not implemented real directly in our setting yet, maybe not in yours either. But hopefully it's a way to open the door toward realistic reimbursement for advanced care planning. Some insurances do a little bit of reimbursement for advanced care planning, but really not very much yet. The other challenge was, over time, sustaining the interest of facilitators and agencies that are kind of constantly undergoing a wide variety of change to be able to sustain their interest in their investment in implementing the process over time, given the other changes that are required of them in other ways. Mark talked about leadership engagement. That's been an ongoing challenge for us, and we've been lucky to have a lot of support from the Stanford organization, but leadership there changes too, leadership priorities there change, enterprise-wide priorities, compete, etc. Another challenge for us has been just logistics of actually changing practice patterns, and we started our program using a few pilot physicians, which was really helpful, a small group of really interested physicians who were supporters for us. Then we would get into the situation where the staff in a particular facility would identify a patient who would be really appropriate for POLST or who had heard about POLST, and that their physician wasn't already oriented to POLST. So that was a challenge for us to figure out how to resolve. As you can imagine, there's a lot of mechanics. Each agency works differently. So each long-term care facility, assisted living facility, the hospital here, the clinic departments here, everyone has a little bit of a different document flow, and to try to arrange for an actual work process or document flow in each organization and get that taught out so people remembered how to use it is a challenge. The POLST document really needs to travel with the patient in order to be able to provide that provider order over a variety of settings. It needs to go along with the patient, and that's been a challenge, to remember to send it along, for people to remember to look at it when it arrives, for example, in the emergency room. And then it's been a challenge for providers to look for POLST, to be aware that it's there, and to actually know how to use it, because the best laid plans are worthless if the provider who is making the decisions at the end of life isn't aware of the document or how to use it. Facilitators, challenging for us. I talked about that. It's a little challenging to decide who to train and when to train. And one thing that got confusing for us a little bit, I think, early on is that we would put a lot of people through the full 16 hours of post-facilitator training, respecting choices training, only to find out that really they weren't in a position to implement or did not wind up actually doing facilitation. So we needed to discover another way to help people learn about POLST and care about it and recommend it without necessarily trying to turn them all into facilitators.
I want to just give a brief example of that. Again, as she said, we trained lots of people with the idea that they would go out and be able to do the POLST and get that word out. But now, the next training that I'm having is only going to be about 4 people, which, you know, it's just a very small group, but it's very targeted to a specific clinic for their needs and their people. And then we're inviting our other POLST facilitators who have already been out there to come back and audit the class. So we'll have more than 4 people, but it's really a targeted one, and that's quite a shift in perspective from when we originally started.
Thanks, Mark. Keeping that group energized and engaged again, facing their multiple priorities, getting over the hump. So we would train people, and there would be a lot of role play in the training about having a facilitated conversation, but actually doing your own first conversation is challenging, and we were lucky enough to have a nice group of volunteers who had been through facilitator training and were skilled facilitators who were able to go into agencies and work with people during their first few POLST-type conversations. It was a wonderful resource for us. Continues to be. Yeah, these people actually, most of them, Mark reminds me, were retired healthcare professionals, or are retired healthcare professionals. We try to keep ongoing support for those facilitators, meeting quarterly with those who are available to come and keeping in touch with them, keeping up their resources, et cetera. Another challenge for us just is, and I imagine you guys will all find this, turnover in critical positions. So, for example, social worker in the hospital gets trained, we're all ready to go with that, and then that social worker leaves and goes to another agency, and you get a new social worker in the hospital who hasn't really had that training. So facilitator challenges, just to talk to, I can make this go. When you think about how difficult it is, even just in one organization, in your own organization, to facilitate a change that actually has staying power, grows legs, and remains an active new process in your organization, think about trying to change processes like that in multiple organizations. So again, the variety across the continuum, clinic, long-term care, assisted living, hospital emergency room, inpatient departments, et cetera. So that is a big challenge in terms of change process. In terms of communication, keeping in touch with all those people, and then all those people connecting with one another around one patient. The quality monitoring, and Mark talked about some of the things we monitor for, and in addition, are the POLST documents being followed? When someone winds up in the emergency room or in the hospital, do their orders reflect the wishes that they are described on their POLST documents? And again, changes in key personnel, either at the leadership level or at the facilitation level. So I suppose we're making it sound pretty much impossible, but remember, we're still here.
Yeah.
So I'm just going to shoot through these next slides. Again, the references are there for your interest, and if you want to write a paper, I'm always about writing a paper. And this is our contact information, and I think they're going to figure out a way for us to take some questions.
Okay, the floor is open for your questions. If you have a question or comment, please press 7 on your telephone keypad. Okay, there's a question from Leah. Leah, the floor is yours.
Thank you. My question is, recently there was a group of us from my place of employment that went through the Respecting Choices Facilitator training. We come from a long-term care facility, and we felt that the initial Respecting Choices training didn't really tailor to the use of the POLST. Is there additional training that is available for us to gain that facilitator type to use the POLST?
So the POLST-type facilitator training is called Last Steps in the Respecting Choices model. So,
okay.
So the first steps, as I understand it, is training really that helps with advanced care planning in general, and then also with the development of an advanced directive for a healthier population. The next steps is for people really who have more chronic illnesses, and the last step is the POLST-type advanced care planning training, and that really is for people who maybe live in a skilled care facility or are within likely the last year or two of life. Does that help?
Yeah, it does. And you and Mark do those POLST-type trainings?
Yes, we can. I'm trained as a POLST instructor, and so is Nancy, so we can both do those conversations.
Okay, thank you.
Thank you again. As a reminder, for a question or comment, please press 7 on your telephone keypad. Okay, the next question comes from Tanya. Tanya, the floor is yours.
Hi, I'm sorry I had to step out for a second, so I'm not sure if I'm asking the same question. I'm interested in becoming a POLST facilitator and just wondering how that process happens.
To become a POLST facilitator, you really need to go through specific training for how to do that conversation. It's really a three-step process. Advanced care planning is an umbrella, and underneath that there's conversations for people who are relatively healthy called first steps, people who have progressive illness called second steps, and then there's training specifically for the POLST document, completing that POLST document. People who are not expected, or for whom the physician wouldn't be surprised that they died in the next year to 18 months because of their illness. So there's specific training for those POLST documents. Honoring Choices Minnesota does that training, and so does Respecting Choices in Anderson and Lutheran. Both of those places you could find that training.
Thank you.
You're welcome.
I'd like to ask a question. This is Pat Tushman. I'm at the Bloomington office. I'm curious, I wasn't clear about how your positions are supported, because it sounds like this is a community-wide effort. And then the other question I had is, are many of your facilitators volunteers, or are they employed by the individual entities with whom you work?
Those are excellent questions, and I'll start out and let Mark chime in as well. Mark is employed by Sanford Health as an advanced care planning coordinator. That started out actually based on grants. So initially we had a grant from Northwest Minnesota Foundation. We were able to support a part-time coordinator, and at that time we were specifically looking at POLST. And we were able to get a larger grant from the Department of Human Services, and that grant supported us for a couple of years and supported Mark's position. Since that time, Sanford Health has taken that over. I actually am an employee of Bemidji State University. So my work for a while, I did a little contract work during the grant when I was on sabbatical, but the rest of us who are not Sanford employees and support the work through an advisory board are, I would have to say, volunteers. Anything to add there, Mark?
Yeah, it's really been an evolutionary process. So we start out with those grants, and that was really community-driven, and the healthcare community, and we had to really convince the healthcare community that this was a good idea to do. And we were able to do that through that grant, giving us the resources to do that, and the healthcare community was a part of that granting process and everything. So, and that's what really got the position I have solidly in there. And then you know, in terms of our facilitators, most of the POLST facilitators are employed by the organization, the healthcare organization that they work with. So long-term care facility, they're employed there. We have about 3 or 4 who have been trained. Well, actually 5 people have been trained in Sanford Health. Only 2 of those people have done POLST conversation, myself and another colleague. Again, it's this workflow structure thing and having that all set up. So that's how most of those. So all of our POLST instructors are healthcare professionals connected to their individual organizations. The community ones that we mentioned, they were employees of Sanford Health, recently retired social worker, nurse, 2 social workers and a nurse, all of whom who had this kind of experience. So we decided to use them in training, to train them, and then they were and just have been doing great work in supporting those other facilitators out there. So long-term care person facilitator isn't feeling real comfortable, hasn't done a lot of them. They call a volunteer, the volunteer goes in and they do it together, that kind of thing, kind of get that process going, getting over the hump. Does that answer your question?
It does. Thank you.
I just want to say one more thing, you guys, because maybe you don't know Bemidji, but a kind of a unique characteristic of the Bemidji area is that Sanford Health has hospital, acute care setting. It has some of the long-term care, but there's other long-term care provided without Sanford Health. And Sanford Health basically has 95% of the primary care providers, so most people receive their care in some way through Sanford Health. So we're sort of connected in a way that may be different from other communities.
And so we're trying to establish the whole advanced care planning process of which part POLST is a part. So of that part, the POLST that we're trying to establish, that really grew out of the community and is still a part of the community in that way, connected. But of course, like all the referrals go through Sanford. So, Sanford is always connected with those two. Any other questions?
As a reminder, for a question or comment, please press 7 on your telephone keypad.
Hi, Mark and Nancy. This is Janelle at Stratus Health. One question I had, I noticed in the title and in some of the slides, you call it a POLST-like process or document. I'm just wondering if you'd clarify what you mean by POLST-like.
I'm not positive what you're referring to, but we do call it POLST-type advanced care planning.
Okay.
Because it's the piece of the advanced care planning specific to that last year of life and results in a POLST document.
Okay, that makes sense to me now. Yeah, thank you.
I think the major challenge is, and this has really evolved from my understanding over the time we've been doing it, is the movement from document to conversation and process. And all of us in healthcare carry that tradition of wanting to fill that document out, get that document completed. Do we have the document? And that really, that focus, to move that focus to, have we had the conversation? Who's going to have the conversation? How will they have the conversation? That is a difficult switch to make. So even the use of the POLST-type or POLST paradigm, we kind of almost in every conversation I have, I try to use it more than just the document, what ends up being the document title. Because again, we just are so culturally in healthcare focused on outcome, on document, and right instead of conversation and process. So, and patient. So that's part of why you see it in there, POLST-type conversation. Even get that thinking about how large is this, what we're doing? What are we focused on?
Thank you. I have one more question unless someone else is in the queue. The form that you showed us, we noticed that there were some elements specifically to your community, but the basic of the form, is that the standard form for Minnesota?
It's also going to be, they're also maybe changing it too, like within the text, to try to update it to have it be consistent with like other things.
Yeah, that's right. It is going to be updated. It is the standard form that we're using. Because we want our program to fit. So if somebody takes it down to Bloomington, they have a POLST, the EMT down there will recognize it. But that POLST is going to be changed quite a bit actually in the next few months, making things like where the physician signs more clear, taking out some of the language that people find ambiguous or uncertain. So there will be some changes coming to that. And then when that happens, we'll have to go out to our facilitators and do some training with them about the changes and what it is. Our goal is to make our program consistent with what we're doing in the state so that there's a consistency across continuum of care as much as possible.
And we do participate in those statewide POLST meetings. There's a pretty active POLST community, decision-making community, I believe out of West Metro Docs that you can find if you Google POLST Minnesota.
Thank you.
Thank you. Again, as a reminder, for a question or comment, please press 7 on your telephone keypad.
We have another question here in Bloomington for the folks that came on site. The question is, how will the small agencies hear about the new changes for the POLST?
Are you specifically thinking of the small agencies in Bemidji?
No, just in greater Minnesota or small, so who may not have somebody on the advisory board or committee.
That's a really good question. And I know for us what we will do, just because we're so involved in this work, is we keep an eye on that website as well as participate in the advisory board. I think the changes will come about, you'll be able to access the new form on that website, but good contacts are Honoring Choices Minnesota and that West Metro Doctors organization out of which POLST comes.
Okay, good. And Startup Health can spread the news too when we find out that the new one has been released.
And as that committee is making those changes and talking about that, we'll make sure that gets raised, and I'm sure that it will. How do we get the word out? Yeah. That's going to be one of the things that they'll be asking too, I'm quite sure.
Yeah, great.
Okay, this time there are no further questions.
Thank you very much.
Thank you so much, Mark and Nancy, for sharing about your journeys here in Bemidji. We know it's been, like you said, a journey, and you're having some great results as a result of it. So this concludes the recording part of the webinar, and then in a moment we will move on to the networking portion.